whenever you look in the index under hypertension, okay, and you see with, and then you run your finger down with all of those possibilities, if the patient has both of those, it has hypertension and it says with, that's a causal effect, and you're going to assume that relationship is there. The only time you do not assume that a relationship is when the provider specifically tells you that there is no relationship there. Okay, so that's going to be very, very important when you read your documentation. Also, when you're wanting to understand the disease process, the more you understand about the structure of the heart, the circulatory vascular system, and the disease process, these guidelines all make sense. So just note for yourself that you can have hypertension and you can have heart conditions, and there will be specific guidelines on how to sequence them. But with inpatient, you always want to remember this. The sequencing is based on the reason that the patient is being admitted or the encounter, right? So why is the patient being seen? Are they being seen because of their hypertension, or are they being seen because of the heart failure, and hypertension is a part of that, right? Well, let me move my cursor here. Hypertensive chronic kidney disease, from the beginning, before the guidelines changed, like in 2017 or 16, when we changed the way we do causal relationships. So if you've been familiar with coding for a little while, ICD, chronic kidney disease and hypertension have that relationship. If a person has chronic hypertension over a long period of time, they're going to have something probably wrong with their kidneys. If they have chronic kidney disease, they're probably going to have hypertension. There is a relationship there as far as the disease process, and it has to do with the anatomy and the way the body works and functions. So when you have hypertension and chronic kidney disease, they're always linked, but they're linked anyway because of the guidelines for causal relationships. But in the past, we just always assumed that relationship. I want you to look at I10. That's when you have a person that has hypertensive chronic kidney disease. So they have hypertension and they have CKD. Okay. If you see a person that has hypertension and they have CKD documented in their admission, then you're going to use I10, not I12, not I10. And then you need to classify what type of the chronic kidney disease that they have, and that's N18. And it's pretty easy for the staging, because if they have stage 1, it's a 0.1. If it's 2, it's a 0.2. If it's a 0.3, 3, it's pretty easy. You've got 4, and then you've got actually 5, and then you have end-stage renal disease that will be classified there as well. So you're going to code the I12 first, all right, and then the N18 point, whatever stage they are, let's say stage 4.4, okay? The only time that you would code that differently is if the patient was being admitted specifically for the chronic kidney disease. Okay, then you might flip that. But as a general rule, with hypertensive chronic kidney disease, it's I12 and then N18.4 or whatever our stage is. There is also a code for acute renal failure, and that is if we aren't staging it as 1 through 4, and I think acute renal failure is in 18.5, but I can't, or 6, I can't remember. So you'd have to look that up. If we have hypertensive heart and chronic kidney disease, so it's one thing to have hypertension. It's another thing to have hypertension and chronic kidney disease. And then it's an additional disease process when you have hypertensive heart and chronic kidney disease, right? So we've got more than one, not necessarily manifestation, but you've got more than one disease process all working together. And when we have hypertensive heart disease and we have chronic kidney disease, then we're going to use for our hypertension I-1-3, right? So we have two things going on, not just hypertensive heart, that's I-1-1, right? If we have the kidney hypertensive kidney disease, then it's I-1-2, but I-1-3 is hypertensive heart and chronic kidney disease. How can you remember the difference? Well, I think of it as you got three things going on. You have hypertension, you have a heart condition, and you have a kidney condition. That's three things going on, so it's I-1-3. Right? And if with that, we're going to have two additional codes appended or code also. So we have our I-1-3, which tells us that, hey, this person has hypertension, a heart condition, and a kidney condition. So the N-1-8 point, whatever our chronic kidney disease stage is, so let's say our 0.4, okay? So we're going to have I-1-3, N-1-8.4, and then we're also going to need to code what our heart condition is. And that's going to be your I-5 code, right? Does it matter whether you put the heart condition in front of the kidney condition or vice versa? It doesn't really matter, but I tend, for me, it's heart and then kidneys, but those two codes won't, it doesn't matter. We can also have hypertensive cerebral vascular disease. Now, cerebral vascular disease is different than hypertensive heart because hypertensive heart tends to be like CHF, okay, which would be your I-5-0 codes. But if you have cerebral vascular disease with hypertension, then you've got I-6-0 through I-6-9. So turning your tabular a few pages over and look at I-6-0 through I-6-9. Notice there that you're going to have your code also and all that other information just like we had with the others, right? I don't see hypertensive cerebral vascular disease as much as you're going to see hypertensive heart disease and hypertensive with chronic kidney disease. It doesn't mean that it's not out there. It's just in the real world, I don't see it as much, but that is because probably I'm not dealing with cardiology all the time. Okay, just be aware that that is a code that's available to you. Often the reason we miss codes is because we don't realize that they exist and they're available to us to get to that higher specificity. So paying attention to the guidelines really helps. However, again, sometimes just that knowledge that they exist is going to be beneficial. I have a moth flying around. It may go across the camera. So if you see that, don't freak out. All right. Hypertensive cerebral vascular disease, I-6-0 through I-6-9. Hypertensive retinopathy. Now, this is different. We're dealing with the eyes, right? This is going to be under H35.0. So then what we're going to do is we're going to do our hypertensive disease category, and it will include that systemic hypertension. So take some time, make a note to go and look at H35.0. What happens if we have hypertension, but it's secondary to something else? Whenever you see this term secondary, that doesn't mean it's secondary listed. That's not what they're talking about. They're talking about that it's due to something else. Now, I'm not talking about a causal relationship, as in, you know, the patient has CKD and so and he has hypertension together. This is secondary. Something happened to the body that caused the hypertension, not a disease process. This is a little bit different. Maybe there was a traumatic injury and thus the patient had hypertension. So the patient doesn't normally have hypertension, but there's a secondary or an underlying etiology cause for the patient to have hypertension. And this is going to be under your I-15 codes, right? And they pretty much, your documentation will always say secondary. And that is a heads up. We're not talking about sequencing in the documentation. They don't necessarily tell you how to sequence. They're not going to tell you how to sequence. That's not what they do. That's our job, is for sequencing. And so secondary in the documentation means, hey, there's some other etiology that has caused this. Really, with this type of code, when we look at sequencing, again, we always fall back on, why is the patient being seen for that encounter? Why were they being admitted? Were they being admitted because of the hypertension, or were they being admitted because of the etiology that caused the hypertension? And the hypertension is, subsequent to that. So then that would be your I-15, and it could be either or. That could be first, because with hypertension, if that is a problem, then definitely they could be admitted for that. Okay, so be aware. Another type of hypertension is called transient hypertension. Now, this is different. This is a completely different diagnosis. You're not going to have an eye. This isn't a cardiovascular thing. And that is R03.0. So make a note. You need to go to the tabular and you need to look at R03.0, transient hypertension. And you're not going to use this unless it specifically states in the documentation that the patient has transient hypertension. We also want to be very aware of hypertension in pregnancy, because anything that has to do with pregnancy is going to be over in your O codes for obstetric. It's very common for obstetric patients to have hypertension, and so that would be transient hypertension due to pregnancy. All right. Your codes will either be 013 or 014. Take some time to look at that, and familiarize yourself with what we'll be dealing with. Another type of hypertension is controlled. Excuse me, not uncontrolled, controlled. Even with uncontrolled, both controlled and uncontrolled, you're still going to code it as if it's hypertension, and you're going to use the appropriate code, either I-10 through I-15, whichever one's applicable. But controlled doesn't mean the person no longer has hypertension. What controlled means is that we're giving them medication and it's working, right? They still have hypertension. It's not cured. It's not going away. It's the fact that the medication is working. So in the documentation, if you see controlled, you just code it just like you normally would. It means the medicine's working. And they're going to test you on that. And you're going to definitely see that in your real world coding. So you code as usual. Uncontrolled doesn't, just like controlled, doesn't have a different code that's applicable. It's still going to be the same code range that you're dealing with. What it means is nothing seems to be working right now. We tried this one medication. We've adjusted the doses. It's not working. We've tried another medication. So at this moment, when the patient's being seen, it's uncontrolled. The hypertension, whatever we're using, is not working at this moment. Can you go from controlled to uncontrolled? Absolutely. Can you go from uncontrolled to controlled? Yes. But the codes don't change. But the documentation is going to change. Does that make sense? Okay. If you have any questions about any of this, remember you can go and ask in the club. And also, if you see anything interesting regarding this or a scenario, please feel free to Share. Now there is an additional one. So now we have I-10 through I-15, and we've applied them, and we know what they're used for. Do you have to have them memorized? I-10, of course, you're probably going to have memorized, right? Because I-10. The others, just be very aware of them. Eventually, especially if you do a lot in cardiology, you probably will get them memorized. It will make you a better tester and a faster coder if you do kind of commit those to memory. But we don't memorize codes because they change. Hypertensive crisis is very, very unique. And it is I-16. This is when the body is, I'm not sure exactly how to explain hypertensive crisis. Remember when we talked about in the endocrine lecture, thyroid storm? You know, this is kind of like that. All right. This is definitely an emergency situation, and it really doesn't have more information except for it says hypertensive crisis, but you may have hypertensive heart disease involved in that as well. So you could have an I-16 code saying, hey, we've got a hypertensive crisis at this moment, okay, and an I-10 through I-15 would be appropriate. So let's say our patient has not transient hypertension. Let's say they are an I-13, and then you code the other appropriate codes with that. But at the moment, they're an I-16 as well. Okay, so you can have all of those in place to tell that story. Moving away from hypertension, let's talk about atherosclerotic coronary artery disease. This is CAD. Now, I'm not going to say atherosclerotic coronary artery disease anymore. I'm just going to say CAD. The codes for that is, well, first of all, they're going to ask you about angina. And usually when a person has CAD, they have angina with that. That's just chest pain. But the chest pain is due to that we have heart disease going on. You're going to look at your codes I-25 for this. And the two main codes that you need to be aware of with CAD is I-25.11 and I-25.7. Now, these are specific codes. This is not a range. Look at those two codes. So turn your tabular over to I-25 and pay attention to 0.11 and 0.7. You're going to see combination codes when we're dealing with CAD. And if your patient has angina pectoris, then you're going to be able to code that in addition. And it's going to ask you, and says use additional code, you know, and that means if applicable, if you have documentation that your patient has angina pectoris, you're going to code that. Now, angina and angina pectoris, two different types. And we'll talk about that a little bit here in the future slides. A causal relationship is assumed unless they state that the angina is due to something else. But for the most part, when a patient has CAD and they have angina, there's a relationship right there. Okay, we have CAD. What's the result of that? We have chest pain. Why are we having chest pain? Because of the CAD. Okay, but you again, unless the provider specifically says that the angina is due to something else, right? Now, what if you have a patient that is a CAD patient and they're having a heart attack? An MI. Now, an acute MI means that they're having a heart attack. That infarction is happening right now. Do not get confused with a patient that has had a heart attack that has CAD, right, and is having chest pain, right? So your documentation is stating that we have a patient that has CAD and they're having a heart attack, an acute MI. So the acute MI, of course, is going to be sequenced first because it's acute, it's happening and right now, and that is our critical condition. The patient just also has CAD. And why are they having the EMI? Probably because of their CAD. Right? If you don't know what atherosclerosis is or CAD, take some time to go out and look at that. Right? Bring up your knowledge base a little bit with CAD. It's kind of an umbrella code. Now, cerebral vascular accident is something that happens with it's a CVA, but it's due to hemorrhage, and you can have intraoperative or post-procedural CVA. If that happens, then the way you're going to code that is it depends why had the infarction or the hemorrhage, and did it happen during the procedure or did it happen after the procedure? Now, you think, wow, there's a code for that? Yeah, there is. Why? Because it happens. It happens commonly. And we need to know that they're not having a CVA because of some type of anatomy or disease process. They went in, they had a procedure done, and they had a CVA during the procedure, right? Or they had a procedure done, and now they're having a stroke, post-procedural CVA, right? And this is a hemorrhagic stroke. There's more than one type of stroke, and so you need to understand the two types. Is it ischemic or is it hemorrhagic? The treatments are different for those, and we'll talk about those. But you do need to know the difference. So make a note in your notebook to understand a CVA, understand hemorrhagic and ischemic, and we need to be aware that intraoperative and post-procedural CVAs are coded differently than regular CVAs. A sequela of a CVA, or cerebral vascular disease, not a CVA, excuse me, is going to be an I6-9. So let's turn to your tabular now and look at I6-9. What happens is we've had a or cerebral vascular disease, right? There is the vessels around the vascular system around the brain is compromised. It's diseased. A lot of times this has to do with age. And now we're having a late effect to that. That's going to be your I6-9. And there's all types of late effects that we can have. You're going to look at conditions, look at I6-0 through I6-7. These are all related to sequelas. All right, familiarize yourself with them so that you're aware that if this happens, that these are codes that you're going to be using in addition. Sometimes you'll have neurological deficits, and that happen after a person has had a diagnosis of a cerebral vascular disease. So understand the difference between a CVA and cerebral vascular disease. A CVA is a stroke, okay? It is a blockage, and that blockage is either happened because of the disease of the vessels or an infarction, a clogging of the vessels, okay? And so that's a stroke where we have a blockage, but we can also have cerebral vascular disease where we have sclerosis of the vessels, or we have a buildup of plaque, just like we have around the heart, in the heart, that vascular area. Let's see, you may have a note for yourself that you can have the I6-0 through I6-7. They actually could be present, or they could happen after the condition of the disease, all right? Sequela, again, is that late effect. You know the code range that we're dealing with. If the patient has a current CVA, they've had a stroke, and they have a deficit from an old CVA, well, then what do you do there? Now, you think, oh, does that happen? Yeah, it happens. When a person has a stroke, they're primed to have another one, okay? Because you don't have a stroke unless there's trauma, acute trauma to the brain for whatever reason, you know, a bleed in the brain because they've been banged on the head or they've had an MVA, a motor vehicle accident or something like that. Okay, that's a little bit different. That's still acute. But if we have some type of disease happening in the cerebral vascular area, those are tiny, tiny little vessels. And your head is very vascular. Everything around your brain is very, very vascular. So once the body has got a disease in those vessels, and we've had you're primed to have a CVA, depending on, you know, it could be either or, the two types, ischemic or hemorrhagic. But once that happens, it could happen somewhere else in the brain, right? Because it's so vascular. Don't confuse the CVA with the TIA. Now, we've talked about that a little bit already when we talked about the CNS and the PNS, the central nervous system. The TIA is a little temporary stroke. They sometimes call it a mini stroke. It doesn't last very long, but it's an indication usually, hey, something's going on ischemically around here with these vessels. And that is coded Z86.73. And you'll see that probably around I69. There'll be little heads up. They'll be in the excludes. So be very careful with that. Now let's move on to having heart attacks. These are acute myocardial infarctions. Even though it says, be aware of your abbreviations. If it says an MI, that doesn't always mean that the person is having a heart attack right there at that time. And because of that, look down here at the bottom. We have an old or healed MI. That's I25.2. If a person has had a heart attack that is past 4 weeks, then it's classified as an I25.2. Just a little note of the disease process. When a person has an MI, an acute MI, they have a heart attack. If they're going to have a subsequent MI, it usually happens within that first 4 weeks, right? That's just statistically, we know that. Why do we know that? Because of coders, right? So remember, we code for statistical purposes, and the disease process is what sets up our guidelines for the most part. So I'm starting down here at the bottom for a reason. So be very aware of the difference between an AMI and an old MI. I25.2 is old MI. And so that's a heart attack that has happened longer than 4 weeks ago. You could have had a heart attack 4 years ago, and it would be an I25.2. If a person had a heart attack 3 months ago, they're an I25.2, right? So let's say a person had a heart attack 2 weeks ago. Are they an I25.2? No, because it's not older than 4 weeks. All right, you're going to get tested on that. You're going to need to know that. 4 weeks is the magic number for an old MI. Now, it used to be farther out. I think it was 8 weeks, but now it's 4 weeks. So don't get confused if you go out and you watch a video or something and somebody says 8 weeks is an old MI. The reason is because it's changed and now it's 4 weeks. So then just pay attention to when that recording or that article or whatever you're seeing was done. So why do we not memorize? Because of things like that, right? Every year there's little changes and tweaks, and it usually is because of the disease process, something we've learned. So now let's go back up to the top. We have an acute myocardial infarction, and there are 2 types of acute myocardial infarctions. There's a STEMI and a non-STEMI. Now, you need to not necessarily understand the difference in the two, okay? We're not providers, we're not clinicians, we don't necessarily need to understand the reason. It would, I think it's interesting in that you should go look at EKG strips, and it will, you know, again, raise that knowledge base up there for yourself. So there's plenty of education on what a STEMI and a non-STEMI is. We've got tons of videos in our YouTube channel about this because I find it very fascinating, and I happen to know that we've talked about it a lot, and I know that Boyd has chopped those up and put them in our YouTube. So take some time to go look at that. But there's other areas that you can look and see education on the difference and what it means. But it has to do, well, it basically has to do with where the heart attack is, the infarction is occurring in the heart. How do we know that? Because when you look at an EKG strip, each one of those lines and movements that you see that goes up, and it goes this, it goes up, it comes down below the line, and then it comes up, and it doesn't. Each one of those means means something specific, whether it's the ventricles working or the arterial, the atriums, and shows a different area there. And when you have a little dip or a wrong movement in the wave, that tells us if it's a STEMI or a non-STEMI. The guidelines around a STEMI and a non-STEMI change. Very specific here. So you're going to have to pay attention to a STEMI and non-STEMI because they're different codes. So if we have an acute MI, then they want to know where the infarction has occurred. Has it occurred, ultimately, is it the bottom of the heart or the top of the heart? Ultimately, that's kind of what it narrows down to. So if you have a non-STEMI, and then it turns into a STEMI, then you're going to assign the code for a STEMI. If you have a STEMI that converts into a non-STEMI, you're still going to code for the STEMI. Now, this is something you absolutely will be tested on. So what does this tell you? There's a code for a non-STEMI and there's a code for a STEMI, right? Because we need to identify statistically, where has the patient had the heart attack? Is it a non-STEMI or a STEMI? The key here to remember is that a STEMI trumps a non-STEMI. So if a person has a non-STEMI and a STEMI, what are we going to code? A STEMI, right? In other words, patient has a non-STEMI, it turns into a STEMI, you code for the STEMI. If a person has a STEMI and it turns into a non-STEMI, you're still going to code for the STEMI. Right. The 4 weeks, if you have anything that's 4 weeks or less, then the patient is in kind of like a global package, and you're going to code from the I-21 codes, okay? Because that is a heart attack. But anything after 4 weeks is going to be an I-25.2. I know you'll be tested on all of that. So if you need more, we give you lots of practice on it. And it's very intimidating when you first start looking at this. Do you need to know the difference between what a STEMI and a non-STEMI is? No, you don't. Now you see why I tell you that, hey, if you go out and you do educate yourself a little bit on what a STEMI and a non-STEMI is, then it'll make sense why the STEMI trumps a non-STEMI when you're coding it, because of the disease process, how it works. Okay? Very good. Now, what if we don't know whether it's a STEMI or a non-STEMI? Okay, we have an acute MAI, a patient comes in and we don't know, well, we got a default. What do you think the default is? It's STEMI. Why? Because the STEMI trumps everything as far as the disease process goes. There you go. And that, so unspecified MI, an acute MI, is going to be classified as a STEMI. You are not going to have an old MI, has its own code. So, you know, the STEMI, non-STEMI doesn't make as much of a deal there, because it'll be in the documentation for, you know, once a person has a heart attack, they know what's going on. They're going to get that information, especially inpatient. They'll have gotten that information. So you have a STEMI or a transmural MI without the site being documented. Well, then we need to find out from the provider, because it's very rare that you don't that you have that happen. Can a person come in and be having a heart attack and then not identified? All they got to do is run an EKG strip, and you're going to have it identified, because the EKG strip tells them if it's a STEMI or non-STEMI. So very seldom will that actually occur. But if you query, or you can't query, you can use I-21.3. Okay, so look at that in your tabular and pay attention to that. And the guidelines will tell you right there that, you know, for some reason, if we can't, you know, what do? We go to I-21.3. Let's see. Oh, so if you have an AMI, an acute myocardial infarction, and it's documented as a non-transmural or endocardial, but the site is provided, you're going to default as a sub in endocardial. And again, this all has to do with the location of where the infarction is happening on the anatomy of the heart. Right? Okay. Thus, if you've watched any of my videos in the past, I always tell you, memorize the bones, memorize the anatomy of the heart. What happens if we have a subsequent acute MI? So we have an MI, and remember I told you that within the first 4 weeks, if they're going to have a subsequent MI, it usually happens within that time. I-22 is going to be the code that you used, that when you have a person that has an MI and they have a new MI within that 4-week time frame, you're going to use the code I-22. That's what indicates that. If an AMI, you could have a definition for other diagnoses. So you may have other things going on, heart conditions and stuff like that. That'll all be coded as well. But you could still use the I-21 code. Sequencing, again, you're sequencing based on what the patient is being seen for that day. Is the patient being seen because of an old MI? No, they're probably not being seen for an old MI. They're being seen for an acute MI or a heart condition, CAD or something else, and an old MI is part of the description of what has happened with the patient. So you're not going to use I-22 for a subsequent MI for type 1 or unspecified. Now, what you need to do is go look at I-21.A1 through I-21.A9. Be aware of that code range and the guidelines that surround that. Right. Next, we're going to look at the anatomy and physiology of the circulatory system. So this is probably a little redundant for you, may just be a quick review. We'll go through it quickly. We have our heart and our blood vessels. And what does our heart do? It pumps the blood through the body, and then the blood vessels is how the blood is transported. And what does the blood carry? Both oxygen and nutrients, right? It doesn't, and actually it covers, it transports other things like, you have your white blood cells, your red blood cells, and you have platelets, okay? But really the function is to get that oxygen and the nutrients through the body, throughout the entire body. The arteries, what do we know about the arteries? Well, they carry the oxygen and the nutrients through the body. And these are red blood cells, right? The largest artery, the largest vessel in the body is the aorta. And the aorta comes off of the heart in that arch that you see when you look at it, and it has like three little fingers that go up, but it comes up off of, that's the aortic arch, and then it goes down through the body. So it goes down through the abdomen all the way down until it branches off to go to the lower extremities. And so you can have an aneurysm of the aorta, and you've got a huge area. That whole large vessel is the aorta, but if it's down lower, it would be called an abdominal. That's the abdominal aorta. You got your aortic arch, and then it comes down, and you've got your abdominal aorta, which is just doing locational. So an AAA is an aorta abdominal aneurysm. Then again, everything is goes off of that aorta. So those three little fingers that I told you, those vessels that come up off the aortic arch, well, they're going to go supply blood to the brain. And then you have two that go off for the upper extremities, and then you have two that go off to the kidneys, the renal, and then you have two that branches down to the lower extremities. Veins. Oh, one more thing about the arteries. The makeup of an artery is it has elastic properties. So it has this elasticity to it because it is got the force of the power of the heart pushing, boom, 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 right? And so that's how it moves the vessels. It's the closest to the heart and the power, and so it's boom, boom, boom. It has to be able to give, and that's how it makes the blood move through the arteries. Whereas the veins are different. They do not have elasticity to them. Instead, we're created with valves because we're farther away, right? We don't have the power of the heart right behind it. And so it doesn't want backwash, right? So it has valves to prevent them it going back down, and it keeps everything moving forward, but it doesn't have that elasticity like the arteries do. So the anatomy and the structure of both the arteries and the veins are different. Their roles are different, but because their structure is different, it's based on what their role is, right? So the veins are taking that deoxygenated blood and the blood that has waste in it and going back to the lungs to get oxygen. So it picks up the oxygen and it sends it to the heart, and then the heart pushes it out, that oxygenated blood, back out to the body through the artery. So it's a cycle, a circle. But what's the purpose of the heart? The heart is just a pump. That's what it does. And its role is to take oxygenated blood and push it out through the body. Okay? The heart, again, is pumping that oxygenated blood. The two major coronary branches come off the aorta, right? So I told you those three little fingers at the top. Two of them are going off the aorta, and they go up the coronary right there. And then the others are coming off the subclavian. And then you have the renal going to the kidneys, and then the lower extremities. Let's see, the heart has actually 3 layers, and you probably need to memorize these. I would say go ahead and memorize everything about the heart. You need to memorize. We have the epicardium, the myocardium, and the endocardium. So if you understand the verbiage, you know the epicardium is surrounding, because epi means around, right? Cardi is the heart. And so the layer that surrounds the heart, that protective layer, is the epicardium. The myocardium is actually the heart muscle itself, the heart itself. Then the endocardium is that inner layer, the inside of the heart. Okay. They are all three different tissue. So if we do a biopsy of the epicardium, that is not the same cells that you get in the myocardium or the same cells as the endocardium. Right? All three are different types of cells. They are not just locational, but locational is how we identify them. The heart's made up of 4 chambers. You need all of this, you need to memorize. You've got, it's got laterality. So we have 2 atriums and we have 2 ventricles. And it's the right and the left. So the right atrium is going to have the blood that comes in from the veins, and that's deoxygenated blood. And then the left atrium actually receives blood via the pulmonary vein. Okay, so then the right ventricle is the pump. It pumps blood to the lungs to get the oxygen, and then the left ventricle pumps the blood to the rest of the body. So the atrium is on top, the ventricles are on the bottom. So the ventricles are the basement, and the atrium is the attic. They're the top. Right? The pump, the power of the heart, is the bottom, the basement of the heart. The ventricles are the pump. Knowing this now tells you why we need to know where an infarction occurred. Did it happen in the powerhouse, the bottom part of the heart, the ventricles? Is this where the infarction and the death of the tissue is occurring? Because if that's a problem, then we're going to lose the ability, the strength of the heart, that power to pump all the way throughout the body. All right. Now we can, if the disease process tells us, then what do we have a problem with? If the infarction happens in the atrium, then we don't have the ability to the power to, or not the power, the ability to get that that blood in, that oxygenated blood out through the body. Okay, it's the receiving end has a deficit, or is it the powerhouse that has the deficit? It makes a difference in the disease process, and ultimately that's where you come up with the STEMI and the non-STEMIs. Okay, there are 4 valves. So you have 4 chambers and you have 4 valves. You have the tricuspid, mitral, aortic, and pulmonary valves, right? And okay, so you got the powerhouse of the ventricle that pushes. The valves prevent backwash. They keep everything running smoothly for the engine of the heart. The blood vessels, of course, we already know. We talked about that, what the arteries do, but the arteries break down smaller to arterioles, and then the arterioles get to the capillary level. Now, the capillary level is extremely tiny, right? When you pinch your finger and underneath your nail bed, it'll blanch, it'll go white, and then it gets pink again. The time that it takes to do that is how they test your capillary refill. That's what that's called. So the capillaries are very, very tiny. This is actually where the exchange happens on the cellular level, is in those little capillaries, and they're systemic throughout your whole body. Then just like the veins, we have venules, right? So that's the arterioles equivalent dealing with the veins. And they turn into veins as you get closer to the heart, right? So what do we have? We have arteries that turn into arterioles, that turn into capillaries, that then turn into venules, that turn into veins, and then we have the heart, and then we have the arteries, and then the process just starts all over again, and it's throughout your entire body. Now let's talk about the lymphatic system. The lymphatic system, I like to think of as a river, and I've probably said this before. So the lymph, wherever you have part of the circulatory system, you're going to have a lymphatic system next to it, right? So we have lots of rivers through our body, and your vascular system as well as the lymphatic system, kind of side by side. The purpose is a little bit in the same, is that it has to transport stuff throughout the body. But remember I told you that the veins get rid of the waste in the body, the deoxygenated blood. And so the arteries are carrying the nutrients, but the veins are carrying the waste with the deoxygenated blood. Where does that go? It leaches out into the lymphatic system. And then the lymphatic system is what cleans the blood, right? And it isn't just like the vascular system. You know how the vascular system, we explain the steps of it. It's set up like a grapevine. So you have the major part. If you've ever seen a grapevine, I used to have one in our backyard. It was really, really cool. But again, if you don't have that to look at, everybody knows what a strand of grapes looks like. So if you've seen a grapevine, though, you have that major trunk of the grapevine. And then it gets smaller and smaller like a tree, but it vines. And then you have the grapes that bud out off of that, off those individual vines. It forks out. It doesn't really fork like a tree, one fork, it's multiple. And then you have the lymph nodes that come off of that. And so you have with your lymphatic system, you will have lymph strands, is what they call them, and then the lymph nodes on top of them. The lymph nodes work with the spleen, thymus, tonsils, and adenoids. They fight infection. They also get rid of viruses that are in our body, and they have lymphocytes. They have specific cells in the body that attack infection, and then that is the lymphocytes. So now we're going to look at the circulatory system and some diseases that happen to the circulatory system. Acute rheumatic fever. Now, we don't see rheumatic fever like maybe they used to have more often, but it is an inflammatory disease and it happens to children. It affects the heart, joint, skin, and or brain. Whenever you have anything that is stated as rheumatic, then know that it's an inflammation, and a lot of times it affects the heart. But it also can do the joints and the skin and the brain. But it seems like the heart kind of gets the brunt of it, I think, sometimes. Infection is ultimately caused by streptococcal bacteria. And a person can have a sore throat, strep throat, and then, or they could have scarlet fever. Either one of those can turn into rheumatic fever. If you have chronic rheumatic heart disease, that means that you've probably had rheumatic fever at some time, and it's chronic, and it kind of comes and goes with attacks. What happens is that you'll get a bout of rheumatic fever. So think of a person having like malaria. If a person acquires malaria, they can have malaria flare up the rest of their life. And that's kind of what happens with this. Chronic rheumatic heart disease means that the mitral valve has been compromised due to the rheumatic fever. And it's chronic. You get mitral stenosis. So the mitral valve hardens, gets stiff, and doesn't work. And it's a valve, so it has to be able to work properly to help the heart serve its purpose. So without that pump of the ventricle into the atriums and back and forth, that valve, you get backwash, right? So the terms that you're going to see in the documentation: insufficiency, incompetence, regurgitation, and sometimes you just see it's MVF, mitral valve failure. Okay. If you have these, then it's usually always caused by rheumatic heart disease, chronic rheumatic heart disease. If you have mitral and aortic valves both being involved, then you know you've had rheumatic heart disease, uh, uh, but unless they've specifically stated that it's not rheumatic, you're going to assume that it's due to rheumatic heart disease. And rheumatic heart disease is coded differently than the other heart diseases that we talked about before because it's rheumatic. Right? Everything rheumatic is in a different area in your manual. Tricuspid valve disorders, you can assume also they are rheumatic unless documentation tells us that it's not. And they will, but mitral valve is the biggie. That's the one that's usually associated. That's the one that gets the brunt of the damage. Hypertensive disease, we've already talked a little bit about that. You can have primary, which is called essential hypertension, or you can have secondary hypertension. But by far more people have just plain old essential hypertension, I-10. The doctor diagnoses this. So if you have a patient that comes in that has a blood pressure of 210 over 100, they do not have hypertension unless the doctor states that they have hypertension. Okay. There is, we really don't know what causes essential hypertension, but we do know that conditions in the body can cause it, like obesity, pregnancy, heart disease, right, kidney problems, and but definitely obesity can cause hypertension. But some people, they think, well, okay, is it because the person was obese? Well, there's people that have hypertension that are very, very tiny and slender. So hypertension is not based solely on a person's weight. If you have secondary hypertension, then again, know that there's going to be 2 codes involved. We already talked about that in the beginning. Hypertensive chronic kidney disease, we've already talked about that a little bit, that it's going to be your I-12 codes. Now, another thing to note, if you have CKD due to diabetes and hypertension, you got a lot of codes to deal with, all right? So you will be able to code that you have diabetes with a circulatory manifestation. Then you're going to also code the CKD and then the I-12 code, right? And the CKD, I mean. So does it matter which is going to be first? Is it going to be the diabetes with the circulatory manifestation and hypertension? Or is it going to be the diabetes with the CKD, right? It just depends on why is the patient being seen. But know that you can have more than one I code there with its manifestations, and you can have more than one diabetes code with its manifestations. So if you have a patient that has DM, CKD, hypertensive heart disease, then you got a lot of codes. You're not going to get by with even 5 codes. It's going to be more than that to describe what's going on. Don't panic because the guidelines tell you what to do. So whenever you see code in addition, then you know if it's applicable, you're going to have 2 codes right there. Code also, code first, right? And sequencing will not be a problem for you. It's all told there. Hypertensive heart and hypertensive and chronic kidney disease. We've already went through the way to code that. The only time you don't code them as related is when the documentation tells you that it's due to some other reason. Otherwise, it's an assumed relationship. Now let's talk about ischemic heart disease. Ischemic is just anything that can go wrong with the heart. Ischemic kind of means heart disease. We've talked about an acute MI, which is a heart attack, an acute myocardial infarction. We can have blockage. That an infarction is a blockage, right? An occlusion of some type. And blood doesn't get to the heart muscle. Or you could have blockage due to fatty deposits, right? That's also known as, you may see it as plaque, but you usually see it as atherosclerosis. So you have arterial sclerosis and you have atherosclerosis. All of these terms mean that we have clogging of the arteries. When you have any condition that prevents the blood getting to the heart, right? Now, we're not talking about out here peripherally of the heart. We're talking about the vascular system of the heart itself, that organ, the heart, right? You're going to have damage to the heart. And heart muscle does not grow back. It doesn't replenish itself, in other words. So once damage occurs to that tissue, it's damaged for life, right? Now, can we prevent further damage? Absolutely. How do we do that? We do a bypass. So if that vessel is so occluded that there's no way to open it up and there's already death of tissue starting, then we take a vessel someplace else and we reroute it and get oxygen to that area. That little patch that has died is dead and gone, but we don't want any further damage to occur, right? Can the heart compensate for the damage that was done? Yes, it can, but it takes time, and that's where you get into cardiac rehab. So a person that's had a heart attack is going to be very weak and frail for a long time until the rest of the heart is able to compensate for the damage that was done, right? Same thing happens to the brain. The brain does not regrow new tissue to compensate for damage. Once the damage is done, the damage is done. But unlike the heart, the brain is really unique in that other parts of the brain can take over the role. And the younger you are, the better it does it. So if you have a child that has any type of brain damage, their rest of their brain can compensate where in ways that are amazing versus if I were to have a brain trauma. So if I were to have the exact same brain trauma as an infant, they're going to recuperate faster and they're going to probably have a lot less deficit than I would because my brain is older, right? And it's really unique how the brain works in that way. But the heart doesn't have that great ability like the brain. Once damage is done, the rest of the heart kind of gets stronger to compensate, but it can no longer perform the function that it was designed to do. That part's dead, okay? So think of it maybe as your hand, okay? If your thumb is not amputated, but it no longer works, okay, they can reroute blood to perform it so that no more damage occurs. But if it can no longer do this, it's no longer doing this. Nothing can make it do this again, right? Can it not die, and fall off and turn gangrene? Yes, but it can't perform this function anymore. So it's just hanging there. And these fingers, these fingers compensate and do things that normally they wouldn't be accustomed to doing to compensate for the thumb? Yes, it can, but the thumb isn't ever coming back. So that's kind of how the heart works, right? When blood can't reach heart muscle, you're going to have damage, and it happens pretty quickly. And the good thing is there's pain, there's signs and symptoms, so that you never mess with anything that is chest pain. You get in there right away to make sure that you don't damage the heart, because the sooner they get in there and vascularize or get oxygen to that part that's starting to die, the less damage that's done. Signs and symptoms of a heart attack. Nah, this is all over the place, and probably most people have these just memorized because heart attack, we know that. But chest pain, shortness of breath, nausea, and pain in the arms and chest. Women and men tend to have signs and symptoms differently as a heart attack. Men tend to have pain that run down the left arm. Women tend to have jaw pain. And again, just go out and study the signs and symptoms. Do you have to have them memorized? No, but it's important for you to know them when you are looking at documentation. Because we don't, outpatient, we don't code signs and symptoms, right? Inpatient is a little bit different, we do, but we want to make sure there's not other diseases or things that we want a heads up on that we're going to end up coding for. Ischemic heart disease is acute myocardial infarction, an acute heart attack, and there are specific tests that we can do, not just run the an EKG, because an EKG could be showing an old heart attack, right? So what the tests are, we can do a CPK, and a CPK is the creatine, it's phosphokinase is how you say that, I think, or creatine kinase. And creatine has to do with your kidneys. So this is a blood test that will have the levels will be off. And then that right away is an indication the person's having a heart attack. They can also do the CPK and an MB. This is something that 3 to 6 hours after an MI, then it will return to normal 12 to 48 hours after a person's had a heart attack. You can do the CPK just usually measure they would do it every 8 to 12 hours to see what is different. The heart, when the heart is being compromised and traumatized in this way, it spills a protein, or not a protein, it spills a hormone. And it's how we know that something's amiss. Other blood tests, they'll check the troponins, the troponin level, and this has to do with that protein. The cardiac muscle will start spilling protein. Now, if you've ever been pregnant, remember how they go and they check your urine all the time, and if they say, oh, you're spilling protein in your urine, that's an indication, hey, something's wrong. And it usually is because your it is going through your kidneys, but it usually has to do with your blood pressure. Okay, and that's what they're checking here, but they can do it with your blood test. Also, they'll have levels that are elevated, will show that damage has already occurred to the heart. You can, of course, they'll do an EKG and ECGs, and that's instant, right? They can run them real quick, but with those, they can't tell if it's happening immediately or was there past damage, right? So they'll go to do these other tests as well. Common areas to have an infarction or death of tissue is going to be anterior, inferior, laterally, posterior, and right ventricle. And what's going to happen is that you're going to see this documented, right? And when you get the documentation, it's not going to just be your regular I2 code. It is going to say we have an anterior myocardial infarction, right? And that's a higher specificity, and that's what you want to get to. Right? We want to know where, we want to document, and for statistical purposes, where the actual damage is happening. If a person has a subsequent MI, then there could be medications that the patients put on, usually for life. There is also, you can go in and do a coronary angioplasty, which is a PTCA. They can do stenting and they can do a CABG. So a PTCA is they go in, and remember I told you that plaque or fatty buildup, they'll just go in and kind of root out and push open and push that fat up against the walls of the artery. Remember, the artery has elasticity to it, but if you fill that up, right, that's a problem. Okay, so smush that fat up against the walls. It has a little give to it. Stenting is where we go in and we push that fat out of the way, and then we put a stent so it can't close up the passageway again. A cabbage is where we're bypassing. So depending on where the damage is of the system, we may take a mammary vein and move it over to replenish blood supply, or we may take the saphenous vein out of the leg and just make a bypass, redo it, depending on, again, where the infarction is happening, right? And of course, thrombolytic in the ER, they're immediately going to put you on blood thinners and medication to try to bust up any clots if that's what's happening. Thrombolytics is called TPA or streptokinesis. No, streptokinase, I think is how you say it. And it dissolves clots if that's what's happening. They have to give it to you within 6 hours of the time from the point that the person has chest pain. If they give that to you, then usually they can bust up those clots. So again, we're not talking about fatty tissue now. We're talking about a blood clot that gets caught. Why did the blood clot get caught? Oh, that sounds like a tongue twister. Because usually there's fatty tissue or fatty stuff in there. And then we always have little clotty type things, you know, that break off and happen in our body, but it got stuck and it occluded. And if we need to bust that up. Side effects, though, is it's a blood thinner. It's a blood thinner. That's why we do not give TPA to people that are having CVAs that are hemorrhagic strokes, because they'll bleed out, right? And anybody that has had an MI usually is on a blood thinner after that for life. So when we code this, what do we need to know? We need to know what is the site of the blockage or the infarction and the death of tissue, right? We need to know, has it happened in the 4 weeks? That's 28 days, by the way. Then it's going to be an I-21, because that's an acute MI. If it's after the 28 days, it's a old MI, which is I-25.2. If it's a subsequent MI, because it happened, they had an I-21 last week and they just came in and they're having a heart attack again, then it's going to be an I-22, because it's within those 4 weeks. You would never assign the I-22 with the I-21, because the I-22 tells the story. The I-22 says, hey, within this last 4 weeks or 28 days, the person's had an acute MI. So it's redundant to say I-22, I-21. You wouldn't do that. An I-22 tells enough of the story. Angina is chest pain. There's more than one type of chest pain, but usually it's associated with some type of heart disease. And if you, and it can indicate that the patient is about to have a heart attack, or they're getting close. They have heart disease. And what happens when you start having chest pain with heart disease? Hey, we got some death of tissue happening somewhere. We better find out what it is. There is an infarction. No, not an infarction. There is some blockages building up somewhere. We need to find it before we have an MI, which is death of tissue. Unstable angina, USA, is different than angina pectoris. Unstable means, hey, we got a heart attack about to happen. You might also see it called ACS, which is acute coronary syndrome. So an ACS is a USA. Just depends how your provider documents that. Also, when this happens, you got to be treated immediately. Right. So you're going to see ER reports and inpatient, that's why you need to know it. If you have a person that has angina chronically, then this is often when they give nitroglycerin. They do sublingual nitro pills, and this happens because of heart disease. So they give you a nitro pill, you put it under your tongue, it dissolves, it kind of goes, it's got a little sting to it. If it doesn't have a sting to it, it's not working. It is exactly what you're thinking. It's nitroglycerin that they put in dynamite. That's what it is. It just happens to be a vasodilator. So if you ever see anybody working with dynamite, they always wear gloves. Nitro paste used to be used in the skilled facilities. We used to put a strip of nitro paste on a patient and put a sticker on them, kind of. Nowadays, you have pre-done stickers that already have the nitro stuff in it, so you don't get it on your hands like you used to. But there's nothing like turning a person over in bed and running your hand up against that nitro paste and getting it on you, or giving somebody a bath. Next thing you know, your brain's about to explode because it is a vasodilator, right? There's protocol for how many nitroglycerin tablets that a person can administer for themselves before they need to go in and be seen. And it's usually like 4 within so much time. After that, if you still have chest pain, you better be getting yourself to the ER. Chest pain or angina is always related to CAD. When you're doing your coding, pay close attention to those causal relationships that we've already talked about. One of the things that you'll see in the documentation is lipid-rich plaque, which means that we have plaque building up in the coronary arteries. And that's why they palpate like this. They want to feel if that's bounding. That's not a good sign. When you have an acute MI, there's usually an underlying cause, and it's CAD. But when a patient's being admitted, what are you going to do? You're going to code for the acute MI and then the CAD. If a person has CAD and they've had a CABG, so we went in and we did some bypass. We took the mammary artery, or we took this saphenous vein out of the leg and we bypassed. Then we need to know that that patient has had a CABG in the past. Statistically, we need to keep track of that. But we also need to know that because it's going to make a difference in how the patient's treated for this current problem that they're having. So if a person has CAD and they haven't had a CABG before, then it's stated that it's a native artery. That a native artery means that they have heart disease, coronary artery disease of the arteries of their vessels that haven't been tampered with, okay? That no bypasses occurred. If they have had a CABG, then it is different and it's not a native artery, okay? The only time that you would code this differently is if the provider specifically states that it's not a CABG vessel, one that's been, not tampered with, but enhanced, I guess we could say, changed, morphed, but for the most part, anytime a patient has CAD and a previous CABG, that's a different code than CAD of the native artery. Know the difference in that. You're going to get tested on all of this. If you code I25.10 for unspecified is used if you have a previous CABG, but it's not known whether it was of a grafted area or the native artery. Right. So it's I25.10, unspecified. Z95.1 shows, and it's a status code, status post-CABG. So if you say your patient's an I25.10 and there is Z95.1 is appended to that, we know that that patient had a CABG, they have CAD, but we don't know if the CAD is affecting that rerouted artery or other arteries, native arteries in the heart. If you don't know, you default with that code. Now we're going to move into the pulmonary circulatory aspects. Pulmonary just means lungs. You could have a pulmonary embolism, which is called a PE. This usually is a sudden onset. It's a clot in the pulmonary artery. This will kill you like that. Because that clot doesn't allow the oxygenated blood to get to the heart. Blood clots or a thrombus. Thrombus is a blood clot, And an embolus is a blood clot that's moving. The signs and symptoms: sudden onset of shortness of breath, severe chest pain, and a cough. The way you determine whether it's a PE is to do a lung scan or a CT. X-rays don't cut it for this. Sudden onset of shortness of breath, severe chest pain, and a cough. You can't get, the airway. This can happen at any age, by the way. And it doesn't necessarily mean that the person has some type of a disease. It could just throw a clot and it hits the lungs. There is a difference between chronic and acute pulmonary embolism. If you have a patient that is an acute, they could be on anticoagulants for 3 to 6 months. And they don't, this means that they probably don't have an underlying disease, chronic disease that's going on. If it's chronic treatment, then they're going to be on, they can go in and they can remove the clot, of course, surgically, but you're probably going to be on anticoagulants for the rest of your life. Pulmonary hypertension is a different type of hypertension. It's not coded with the other hypertensions. It's not an I code. That is going to usually happen when you got pulmonary systolic pressure. This is pulmonary systolic pressure of 12 to 20 or 18 to 25. You don't necessarily need to know that. There's 2 types though: primary pulmonary hypertension and secondary pulmonary hypertension. The PPH, primary pulmonary hypertension, means that's what that you have pulmonary hypertension. Secondary, of course, means it's caused by something else. If you're looking at the documentation, the normal pulmonary systolic pressure is 18 to 25, but you don't, again, need to know that. But it helps to be aware. It's rare. They don't know what causes primary pulmonary hypertension, but it is progressive and it's fatal. So they've been doing a lot of study, but they do know that way back in the day for obesity, this drug came out called Fen-Phen, and I actually took Fen-Phen when I was just starting to get fat. It was great. It was like taking speed, but it is definitely been linked to pulmonary hypertension. Now, I don't have any problems with that, and this was eons ago. This was not 30 years ago, between 25 and 30 years ago. People had mitral valve damage because of Fen-Phen. That's why it was taken off the market. How can someone get secondary pulmonary hypertension? It usually is because of things like COPD, lung disorders, emphysema, or they've had a PE, or obstructive sleep apnea, they've said could also be a cause of that. If it's untreated, then what's going to happen is you're going to have right ventricular failure. So that pump, that powerhouse on the right side of the heart, there in that basement of the heart, it's just going to fail. It's going to give out. Dyspnea, or shortness of breath on exertion, fainting, fatigue, and chest pain. Those are your major symptoms of pulmonary hypertension. You have to seek treatment. They can sometimes work on the underlying cause. If you're getting pH due to COPD, well, then the better control that we have over your COPD will help the pulmonary hypertension. But for the most part, they give you vasodilators. They give you diuretics, so you don't have buildup of fluid, that pressure, that makes the heart struggle. Anticoagulants, of course, sometimes the person's put on oxygen, and sometimes digoxin. If they need to, they have actually done lung transplants for that, but it's really severe. Pericarditis. Remember what we said the pericardium was? Surrounding the heart, protecting the heart. If that gets inflamed, then it's called pericarditis. What causes pericarditis? Well, sometimes if a person has that, it's some type of a viral infection that causes that. Or a person can have AIDS and get pericarditis. If a person has a heart attack and they can develop pericarditis, also, for the most part, it's viral, but sometimes they have bacterial infections that will cause pericarditis. What are your symptoms? Just like you would expect: chest pain, breathing difficulties, fever, and cough. It's an inflammation. It's an inflammation. They'll say it's an inflammation of the heart. Well, it's the surrounding of the heart. This can happen to your lungs too. You know, you have a sac that surrounds the lungs. Anything that moves constantly is going to have a protective slick layer around it. They can see this on a chest x-ray. They can do an echocardiogram or an MRI. Patients sometimes may have an abnormal EKG. Now, that EKG isn't showing a heart attack, but something's not right because the heart's inflamed. It's struggling. Let's see, inflammation to the inside lining of the heart. That's endocarditis. We already talked about where that, the cause of that's usually bacteria, because the inside of the heart, right, has the blood flow. The outside of the heart has external blood vessels, but the inside of the heart is actually touching all that blood that's going through the body. What's going through that blood? White cells, as well as red blood cells. Remember, we have to get rid of the waste. It goes through the blood and gets into the lymphatic system, so we could run bacteria through. The risk that you have is that the heart gets so inflamed and kind of swells, right? And it can't perform its function. The people at risk tend to be intravenous drug use. And we're not talking about getting IVs. We're talking about people that shoot up into the veins. Central venous lines, if you have to have an IV for extended period of time, or if a person has a valve replacement done in their heart, this can happen. Symptoms are going to be fever, shortness of breath, fatigue, night sweats, and muscle aches can all be in there. We can test for endocarditis. Blood cultures and endocardiograms will tell us. The only way to treat it, IV antibiotics and probably anti-inflammatories, I would say, most likely. But you got to go to the hospital. They got to treat you for an extended period of time on IV antibiotics. We talked about other heart diseases. We talked about rheumatic fever. If a person, remember, has any valve damage, they assume it's rheumatic in origin. But what if we do have documentation that it's non-rheumatic valve disorders? We can still have incompetence of the valve. We can have insufficiency where it just doesn't work as well, and regurgitation, that backwash. Or sometimes you'll hear it say, it'll say leaky valve. I had a leaky valve. So when you code that, you're going to code that differently because you have documentation saying that it's non-rheumatic. So then we need to know what caused it. First of all, we want to know what valve is being affected. Now, when it's rheumatic, it tends to hit the mitral valve first, but it can hit all of them. But often in the documentation, it tends to be, I see mitral involvement. You could have more than one valve. You could have mitral and tricuspid, you know. Oh, but we need to know what the non-rheumatic reason was. So you may be doing combinations of more than one valve, and we may be putting other information in there saying as to why we had that. Cardiomyopathy. What do you think that is? Well, cardio is heart, myo is muscle. So we have something wrong with the heart muscle. That ends up being things like the CAD, of course. We can do infection. Diabetes really affects the heart. Alcohol abuse can cause cardiomyopathy. Whenever you code for cardiomyopathy, you're going to code for the cardiomyopathy, but you're also going to code for the underlying condition. So was it diabetes? Was it CAD? You know, what was it that caused the cardiomyopathy? The way we determine it that the person has cardiomyopathy is an echocardiogram or echocardiography. The treatment, well, they can give antibiotics if you have an infection, but they also will treat whatever that underlying condition is. So if it's CAD, you're treating the CAD. If it's alcohol abuse, you're going to treat the alcohol abuse, right? Conduction disorders. Now, I like to remind people that the anatomy of the heart, right? We need to know that, but there's 3 things you need to know about your heart as well. It's muscular, it's electrical, and it's chemical. So yes, the muscles, that's the powerhouse. How does the powerhouse know how to work? What keeps it going? The electrical current. And that happens in we have 2 nodes in our heart. We have a VA node and an SA node. And then we have an area in the middle that's called the bundle of His, and they communicate. So it's like 2 little electrodes bzz, 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 that keeps that heart going. And then the chemical aspect of our heart, remember I told you that you spill proteins, hormones, that they can tell by blood tests, the creatine in your kidneys is off. All of that is indications that something's off with the heart. But our heart runs also with calcium and potassium. So if our calcium level is too low in our body, then the heart will get irregular heartbeats. Same thing with potassium. And that's another reason why when a person has a heart condition and they put you on diuretics, they also give you potassium, because diuretics not only let the fluid flow out of the body, but it sucks the potassium out of the body. And without that potassium in the body, then your heart is compromised, because it's muscular, electrical, and chemical. 3 things. So the electrical impulse regulates the beating of the heart. Boom, 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 boom. Those SA and VA nodes talk to each other, and the bundle of His is a little powerhouse that works together. So think of when you go to plug something into the wall, the bundle of His is the cord, and then you know how you got one little end of the plug that's bigger than the other. So think of that as one is the VA node and one's the SA node. You plug that in, and it powers up the heart. Just so you know, normal for an adult is 60 to 100 beats per minute. The healthier you are, the more athletic you are, the lower it tends to be. Tachycardia means you have a fast heart rate. Anything that's above 100 beats is going to be tachycardia. You do not assign the diagnosis of tachycardia. If you have a patient that notices that in their vital signs they have a heart rate of 122, yes, they're tachycardic, but that doesn't mean you code for tachycardia unless the patient has that documented by the provider. Bradycardia means slow, anything below 60. And how do you remember the 2? I remember that fast women were tacky. Because you hear that old thing. So if it's tacky, it's fast. Brady, I think of the Brady Bunch is kind of slow nowadays. If people watch that, it's like, that's not a lot going on there with the Brady Bunch, you know? And so that's how I remember. So if you have a block, there's a 1st degree and a 2nd degree block. This is conductions of beats. So you got upper and lower are the slower than normal. And then if you have 2nd degree, then not all the beats are actually going to from the upper to lower. 3rd degree is impulses can't pass from upper to lower. So it's conduction problems that are happening with that SA and VA node in that bundle of His. Cardiac arrhythmias. So we have that lub-dub, 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 lub-dub. An arrhythmia is when you're going to go lub-lub-dub, lub-dub-dub, or you have it's not going boom, but, you know, lub-dub, lub-dub. It's going lub-dub, lub-dub, or it's going lub-dub, lub-dub. You know, those are all arrhythmias. It's irregular rhythm. And what's off? The electrical impulse, right? Because that's what's telling us to beat charges. What causes that? Well, if there's problems to that part of the heart, but it also could be you're too low on calcium, things like that. The normal sequence is your right atrium through the AV node, through the bundle of His to the ventricles. That's the pathway. Then you can go out and look at these on YouTube's YouTube channels. There's all kinds of really interesting things that Khan Academy does some really great stuff on this. Abbreviations, if it's arterial fibrillation, it's AF. If it's sick sinus syndrome, it's SSS. This is pretty common. SVT, it's supraventricular tachycardia. And all of those have to be treated. Okay, so AF, SSS, and SVT are all different diagnoses of cardiac conductions or disorders or arrhythmias. If you have cardiac arrest, now a cardiac arrest is not the same as a heart attack. A heart attack is an infarction. It's a blockage of the blood to a specific area of the heart that's causing death of tissue. That's an infarction. A cardiac arrest is the heart stopped. There's no lub-dub at all. It's just stopped. There's no movement. Okay? Two different things. So principal diagnosis, whenever you have a person that comes in with a cardiac arrest, they're dead. They're dying. So they die before the underlying cause is established, then you can use a cardiac arrest as that diagnosis. If a person presents to the hospital in cardiac arrest and is resuscitated, then they're admitted and then subsequently dies before they can determine what the reason for the cardiac arrest is, then you can use that as a principal diagnosis, but you're not going to usually use a cardiac arrest as a principal diagnosis. It becomes a secondary diagnosis when we know what caused the cardiac arrest. So if a person comes in to the ER in cardiac arrest, they're resuscitated or before, anytime the heart stops, it's arrested, then you can use this code, but it's not usually a principal diagnosis. Do not code when the patient or the physician says cardiac arrest as the cause of death and there is no resuscitation. All right. You do not code secondary, that you're not going to code that as the reason cardiac arrest. Heart failure, those are going to be caused by CAD, MIs, cardiomyopathy, hypertension, valve disease, diabetes, CKD, all of those can cause heart failure. And now it makes sense why we have that causal relationship that we talked about at the beginning, right? Side effects, well, ultimately, we're not getting enough blood to the kidneys, or we've got too much fluid buildup. So with heart failure, you often see edema. There's going to be congested lungs, difficulty breathing, edema, especially in the lower extremities, fatigue, and an irregular heartbeat. Classic signs. CHF, very, actually pretty common, especially in our older generations. So heart failure, though, can be divided up in so many ways, and we always want to get to the highest specificity. So we don't just want to code CHF that ends in a 9. No, we want to know, is it systolic heart failure? Is it diastolic heart failure? Is it due to an ejection fraction? And know that you can have systolic and dystolic, systolic and it's diastolic. Sorry saying dystolic, but systolic and diastolic heart failure. And then you can have them separately, you can have them together, and then you can have systolic on diastolic. Okay, that's a completely different diagnosis. And ultimately, what you need to know is that in the documentation, you're looking for that verbiage to get to the highest specificity. So when you go to look in your tabular at heart failure, look at first the index, look up failure, heart, and then you're going to have all of this information listed. It's going to give you all these possibilities. Then go out to the tabular and look at the rules about sequencing around that. Injection fractions, it'll be documented for us. We don't need to know that a normal injection fraction is 55 to 70%, but do know that how we determine that, because these are going to be tests we're going to see in the documentation. We're going to have an echocardiogram, we're going to have MRIs, we're going to have a gated MUGA, MUGA, or a CT scan done. With heart failure, there are blood tests that can be done. Brain, now, let's see how if I can, it's uretic. It's natriuretic peptide, and because it's just called BNP, nobody says that. That's why it's hard to say. But that's where you're spilling protein, okay? So that hormone produced by the heart, hey, it starts dumping. Something's wrong. When they do that test and they find that BNP in the blood, that's just like being pregnant and having protein in your urine. Something's wrong, right? They don't want to see protein in your urine. If you're at the end stage of your pregnancy, 38 to 40 weeks, and you're spilling protein, they're probably going to go induce you and get that baby out. And the same thing, if they see this BNP in your blood, you got some heart failure going on. We don't need to know normal ranges really, but we do need to know that if we see BNP documented, we're probably going to have some kind of a diagnosis of heart failure. Now, other tips about that CHF, okay? If you have a documentation of systolic or diastolic heart failure along with CHF, you're just going to code the systolic or the diastolic. Okay, it's not CHF, it's systolic heart failure or diastolic heart failure because we're getting up to the highest specificity. We want to look for acute, chronic, and acute on chronic. 3 different diagnoses. So first we need to know, is it systolic heart failure? Is it diastolic heart failure? Is it systolic and diastolic at the same time? So we got to answer that question first. Then we have to have another question. Second question, is it acute? Is it chronic? Or is it acute on chronic? Second question, all right? And that's going to get us to the highest specificity. Now, documentation with heart failure as pulmonary edema. So there's other things that can cause pulmonary edema, but really the number one reason a person has pulmonary edema tends to be heart failure. The lungs start getting flooded, weighted down. There's a backwash of fluid. And if a person has CHF, they could have pleural effusions as well, right? So if you see CHF, you're going to want to pay attention to the codes because it'll say with or without pulmonary edema, right? Now, pulmonary edema is not the same as a PE, pulmonary embolism. And usually the way they don't usually say PE when they abbreviate that, but they may say P edema. But people don't handwrite that stuff like we used to. So that isn't necessary. They'll type it out. Heart failure, also be very aware, of course, of the pleural effusion and then any other diagnoses that may be specified. And pulmonary edema would never be coded with CHF, all right? That's going to be in your excludes, just so you know. Cerebral vascular disease, just checking back with that. So we have a brain infarction, which is death of tissue, or a CVA. It is a lot like your MIs, right? We already talked about that. That vessel for the brain is blocked like a vessel for the heart, and cells die. The brain cells die. There are several types. There is ischemic stroke. So that means that there is a disease of the blood vessels, and it could be, causing us that type of a clot. 80% of strokes are ischemic. Okay. Now, ischemic stroke is the treatment for ischemic stroke is different than the treatment for a hemorrhagic, because with an ischemic stroke, we can give them TPA. Okay. If you see in the documentation that TPA was given, then you know it was an ischemic stroke, because we wouldn't give TPA to a hemorrhagic stroke, or you would kill them because it's a blood thinner. Ultimately, sometimes you have a clot or an embolus that develops that pushes up and gets caught in the brain. They could be also caused by just stenosis of the arteries. You know, they could have a buildup of plaque, and they can have small or large vessel disease, which is called lacunar infarction. Unal means like a tube. Hemorrhagic strokes, though, are different. That's kind of where we've had a bleed, all right? Maybe an aneurysm and a bleed that has happened. This is a inner cerebral hemorrhage. And we can also have a subcarotid, let's see, subarachnoid hemorrhage. I gotta say that right. AVMs are arteriovenous malformations, or plaque can cause these aneurysms, AVMs. If you have an infarction with a hemorrhagic conversion, you need 2 codes. Okay, so we need one for the infarction, the death of the tissue, and one for the hemorrhage. With strokes, signs and symptoms, you're going to have a deficit on one side of the body or not. Remember, with the laterality, we default to right side dominance if we don't have the documentation, and you may not get that in the ER if the person isn't able to be a good historian. Weakness, numbness, you can have confusion, trouble walking or speaking, dizziness, headache. The way to test for that is they go in and they do a CT scan or an MRI, and the thing about an MRI is that it can see smaller than a CT scan can. So often they'll go ahead and just do an MRI. Treatment, if it's hemorrhagic, we're not going to give them TPA. We're going to try to go in and stop the bleeding, repair it. If it's ischemic, then we'll give them the TPA. TPA, also know that if they give that to a patient, it's I6 3.9. It can be appended, and TPA has to be given in within a specific amount of time after the signs and symptoms started, or it's not effective. But it's a real game changer in the before we had that. Anticoagulant, antiplatelet agents are given. Any deficits that the patient gets because of the strokes would also be assigned. Carotid artery stenosis, CAS, that's different than CAD. It's under occlusion. So how are we going to find that? So we're going to look under, in the index, go look at occlusion artery carotid. All right. If you have an infarction and it's due to that stenosis, then we need to know, was it bilateral? All right. So do we have stenosis on both sides of the carotid arteries? Stroke is the leading cause of disabilities for our older patients. And if you have a stroke, then we need to know what the current deficit is, and also you'll always be tracking any sequelae or late effects as well. When we have atherosclerosis or arterial sclerosis, that is affecting the blood flow through the arteries, okay? That's not the veins, this is the arteries. Ultimately, we get plaque buildup. Sometimes we can have a rupture of that plaque and it gets caught, right? The clots that occur can block both heart. It can go, it can get through the heart and make it up to the brain and cause a stroke, or it can cause claudication, ulcers, and gangrene in the extremities, especially the lower extremities. If you need to do this, code for this I70.2, go to your tabular and look at that. Pay attention to I70.2 and the excludes, as well as the indications to how to sequence that. Aneurysm. Aneurysm is a bulging of an artery, okay? This happens because of atherosclerosis. And the thing about that is, you know, if you have a cerebral problem, sometimes headaches, you know, can occur because there's not a lot of room going on. But if you have an aortic aneurysm, you may not know it until you're dead. Because if that ruptures, you're going to bleed out pretty quickly. But there is signs and symptoms for uh, uh, lower down in the abdomen. So if you have an AAA, then sometimes they exhibit pain like as if they're having a kidney stone. So if a patient's never had it, let's say they're 75 years old, they've never ever experienced a kidney stone before ever, then that could be an AAA. Uh, uh, so again, that's not necessarily for us to know, but that is for documentation, heads up on what to look for, getting to the highest specificity, and makes us a faster coder. When we know what to expect, if we can see it coming, then we know when we do see it that it's documented, then we know what code to grab. Usually this will happen anywhere in the aorta. Remember, we got the heart and that arch that comes up and it goes all the way down till it forks there to go to your legs. It can happen anywhere in that major vessel, the largest vessel of the body. Rupture is life-threatening. If it ruptures, and hopefully you're already in the hospital, because if it ruptures outside the hospital, you usually succumb, you bleed out within minutes. The larger the aneurysm, the larger the risk. The terminology you'll see is type 1, 2, and 3, and that's describes dissecting the aneurysm, where it's located at. Treatment is they will go in and wrap it, close it off. Sometimes they'll literally stitch it up. So the endovascular surgery is the only way. Well, they can do open or endovascular surgery to repair that aneurysm. For dissecting aneurysms, there is more than one classification. There's Stanford, which would say it's type A, which means the ascending aorta requires surgery. Type B means that it may be managed medically. We're treating it with medication. DeBakey is going to be type 1, would be ascending aorta, aortic arch, and descending aorta. Now remember, ascending aorta, aortic arch, descending aorta. The type 2 is ascending aorta. Type 3 is descending aorta distal to the subclavian artery. Anything below there, down. And then its subcategory is 3A and 3B. If we have arterial venous fistula, ultimately that means we got a narrowing happening somewhere in the arteries or the veins. The passage is abnormal and it can cause complications. This can give us varicose veins. This can give us problems with the arteries as well. The blood can bypass the capillaries and go directly to the vein. Other conditions that happen to the lymphatic system is going to be things like phlebitis. Now that is literally an inflammation of the lymphatic system. Deep vein thrombosis is a DVT, usually happens in the lower extremities. Varicose veins, and varicose veins is the valve system that's in the vein, just wears out. So either one side doesn't work anymore, both sides, and then it just regurgitates and kind of overflows its banks like a creek and bulges out along the sides. Usually it happens in the lower extremities, but you can also get varicose veins in the esophagus, right? And there can be complications. And if it gets to the point that you have complications in like a varicose vein of the leg, they can go in and strip them or give other treatment to break them down, make them smaller. You can also have stasis dermatitis. Now, dermatitis, again, is a condition of the skin, inflammation of the skin, but stasis dermatitis specifically has to do with the circulatory system. So what's happening is we're seeing a swelling, like say of a leg, and the skin starts to turn a little purpley, and then the skin will weep that fluid will leak out of the, like when you scrape your knee, you skin your knee, and that little serous fluid that builds up to protect, that's kind of starts leaking out through the skin. The reason people get this, it would be obesity, if they have high blood pressure, chronic high blood pressure, and varicose veins, or all three can cause this. You can also get this from heart and kidney failure. People will have that. So some Z codes to be aware of. We've pretty much the same as the ones we've looked at, but personal family history of, post-procedural status. So was something that we're seeing here caused because as a result of a procedure, and this is after the procedure. Awaiting organ transplant status. So I'm awaiting a heart transplant. Fitting and adjustment of. We're going to fit and adjust for a stent or something. Aftercare following surgery, aftercare for the MI. Observation for suspected condition. We have a suspected MI. Pre-op cardiovascular exam and special screening for. Medications and treatments, just real quick. If a person has angina, then of course nitroglycerin being the biggie that you'll get. Beta blockers though, and calcium channel blockers. These are all pretty common. Corig, low pressor, and Norvasc. But remember I told you your heart is chemical? Maybe you have too much calcium. We need to work with a calcium channel blocker. We're going to regulate the calcium. AFib, blood thinners. So they'll put you on things like Coumadin and Plavix. This Ticlid, I don't know that one as well. Rate control. So we have bradycardia or tachycardia. Again, we can use those calcium channel blockers to do that. That would be cardizem or verapamil. Beta blockers, atenolol, low pressor, Inderal, digoxin, linoxin, all are used to help the rate of the heart. If a person has CHF, we're going to probably put them on a diuretic to help, because it builds up fluid both in the heart and the lower extremity, the lungs and the lower extremities. So your common is Lasix and Bumex, but they also may put you on some beta blockers. Hypertension, well, they put you on a diuretic, and they could put you on Lasix, but a lot of times they'll use aldactone, but they'll put you on beta blockers, atenolol, Vasotec, Cozar, Calalane, or whatever, Cardizem, and Aldamet are all common that you'll see in the documentation. Now let's talk about the PCS codes. If you are doing a diagnostic cardiac cath, keyword diagnostic here, then you're going to have a patient that's probably coming in with chest pain, angina, some acute MI. Look for, they're going to be looking at the heart chambers, the valves, the arteries. They end up doing a needle or a cath into the vein and going up and looking at the heart. Sometimes they go in through the groin, which I think is pretty well, it depends. If they're going to do a right heart cath, then they go in through the axillary area or the groin, the axillary in the arm. But if they're going to do a left heart cath, they're going to go in through the groin. Make a note of that, because if you're coding procedurals and if they go in through the groin, you know it's a left heart cath. Okay, same thing with the right heart cath if they go in through the arm. Okay. That's a giveaway. That helps you be faster. Insertion point, again, very, very important. So it's going to be the femoral artery, which would be the groin. And then sometimes they put dye in as well, so they can get a picture of the arteries to see if there's any strictures and stuff. Angioplasty is called a PTCA. They do it for blockage of the arteries, and they can go in then and remove the plaque and do an atherectomy. So can they do an angioplasty and atherectomy at the same time? Yes. Catheter is going in, they like shave it or do literally roto-rooter. Laser is also performed for atherectomies. That's kind of cool. Will they put in a stent? A lot of times a stent will be placed, and they may do more than one stent. Now there's two types of stents they put in when they do angioplasties. They could do one that is drug eluting, which is DES, so it kind of like releases a blood thinner so we don't produce any more. And then a non-drug eluting. Okay, two types of stents. What are we doing? We're wanting to prevent stenosis happening again. And the drug-eluting stents are not to be confused with stents that are coated with antiplatelet drugs. Antiplatelet drugs. Cabbages or a CAB. Bypass. We know how that's done, and we've talked about that already. The two places they like to get veins is either to pull the internal mammary over, or they grab the saphenous vein out of the back of the leg. If they take the saphenous vein out of the back of the leg, you're going to be coding for the repair and the harvest of that as well. So heads up. Documentation. We need to know how many arteries are we going to bypass? Where are they being bypassed from? So if we're doing more than one coronary artery site, we're doing something, then we need to be aware. And harvesting or bypass of the graft. If we do an EPS, that's an electrophysiological study. We're looking at the electrical conduction of the heart. We're checking the VA, SA nodes, and that bundle of His. They'll go in and they'll put a catheter. They'll go into the vein of the leg and they'll thread it up into the heart, and they'll literally check the pressure. And they can also go from one side of the heart to the other by puncturing and going through the septum. Let's see. They also can administer stimuli, zap it at that time to see what the heart's response is to that. Definitely extra codes. They can do an ablation. Now, why would they do an ablation? An ablation is where they're going to take off, they're going to burn off tissue. Because if you have an abnormal heart rhythm, if they burn off a little abnormal heart tissue, then sometimes that will correct the problem. They can do an RFA, which is a radio frequency ablation, and they have a special catheter that does that. They can put in a pacemaker, and I think for the most part we're pretty familiar with pacemakers and how they work. They keep the heart at a regular rhythm. The pacemaker can have two functions. What it senses when the heart is out of rhythm, and then they can maintain that pacing of the heart, right? So it monitors as well as keeps that heart pacing. Now they also have pacemakers that have the ability to zap you, right? And so they can do. They got devices that have batteries and electrodes. They have more than one electrode or leads on there. All of this is pertinent as to what type is being placed. If you're not familiar with the different type of pacemakers, go take some time to go and look at those, because pacemakers, once you get it, it's really easy to code for those. But ultimately, there is a little nuances as to all the different types. So if you're familiar with the different types, then it's fairly easy to do. Permanent pacemakers are put under the skin in the chest, but you're also coding for a pocket to be made for that pacemaker, not just the insertion and implantation. The wires or leads, they're going to go into the veins and then they put them into the heart, but the pacemaker is the little battery, the little brains of it. So you're going to have a code for the insertion of the generator device, insertion for the leads or electrodes, and you'll have a code for making the pocket for it to sit in. They can do pockets for epicardial leads in the abdominal wall. And this would be if you have a child that's growing and they don't want to put it up here. It takes up space. And there are separate codes if we have to remove either the device or the leads for whatever reason, or we need to replace the device and the leads. Those are all different. So The principal diagnosis, again, we're going to pay attention to that. Are we going to remove, replace, or reprogram the pacemaker? If we're going to do an AICD, that is an automatic implantable cardioverter defibrillator. Now, there are some pacemakers that are defibrillators also. They do them together. But ultimately, if you have this defibrillator planted, if a person ends up with tachyarrhythmias, it will zap the heart and put it back in rhythm. This is a pulse generator, and it gives a shock. It's like a converter to the heart. It also has replacements and leads and etc. If we have a biventricular pacing, we will have cardiac resynchronization therapy, CRT, and this is a standalone code, by the way, for this. It's a built-in implantable cardioverter that goes in ICV, and they use that for heart failure. There's leads and generators, just like all of those. That's why it's like a good idea to understand the difference of these. Let's see. If you get a biventricular pacemaker, that actually uses a third lead. Okay, most of them are 1 or 2 leads, but a third lead is usually a biventricular pacemaker, and they not only help with syncing, but it works on the left ventricular vein of the coronary sinus. They attach it there, and then it causes both ventricles to contract at the same time or stay in sync. Let's see. Oh, okay. I thought it delayed. Biventricular pacing does not increase the heart rate. Interesting, right? So if you have patients that have a fast, irregular rhythms, they have tachycardia and it's irregular, they may put in these biventricular pacers. They have biventricular pacing, anti-tachycardia pacing, and internal defibrillators. They can put them all in one. But when you code that, you're going to be doing an implant or a replacement of both systems. So it's going to say with ICD or without ICD. Okay. Aneurysms, what are they going to do? They're going to do resections. They're going to either do an open approach, and they'll do an anastomosis or a graft repair to those. If they do an endovascular repair, then they do an endograft, and it goes up through the femoral artery and in via a catheter, and then they can do the repair. The advantage of that is that they are going to not have to cut you open, because if they're going to cut you open to fix like an AAA, we're not talking a small incision, right? They got to open you up like this, and they move all your organs out of the way. Now, the other thing to note is that if a person is acute and it's causing a problem and it's an emergency, they're going to open you up, usually, I think. Central lines and catheters, why would we put in one? Chemotherapy, key. TPN, total peritoneal nutrition, so we got to go in and feed straight into the digestive system. Antibiotic administration and dialysis. So that's why we would put in central lines or catheters. Names are going to be Hickman, Groshong, and triple lumen. Those are going to be the ones that you hear in the or see in the documentation. So remember, I told you the lymphatic system is like a river. I came up with this great quote, and it says, "A river cuts through rock, but not because of its power, but because of its persistence." So this is all a whole lot of intimidating information, right? It's a lot to take in. The guidelines are intense and everything. So don't worry. You don't have to cut through it right away. Don't plow through it and think it's all going to get there. Persistence, repetition, increasing your knowledge base, slow and steady. That's what's going to get you through. So I thought that was kind of pertinent. And isn't that a great picture? All right, guys. Hey, we did good today. I love, love, love this information. And just so you know, As people age, things just happen with the cardiovascular system. Okay, it's part of the aging process. So, you know, this is everything that we've talked about today. You are going to be exposed to a lot in coding. The only time you wouldn't be exposed to a lot is if you specialize, say, in pediatrics. You know, and even then you could be exposed to it because some of these conditions can happen to children. All right. So if you have any questions, don't forget to put them in the club. And if you see anything interesting that you can share with everybody, do that as well. If you just happen to be joining us on Facebook or YouTube for some reason, don't forget to like and subscribe, but go check out the club because that's where you get to see these great lectures more often. All right. Bye, guys.